everybody, Mr. Supply Chain here with two real experts talking about a critical issue at a really important time for all of us. You know, for the past few months, I've been talking about how important it is to think about the people who work in our supply chains, what we need to do to protect them, and also how we protect our suppliers and our customers in the middle of this global pandemic. Really fortunate today, I've got with me Dr. Matthew Akampura and Dr. Neil Carl from Wellcome MD. We wanted to talk a little bit about what they're seeing with their patients and how they're responding to the COVID-19 contagion. And really what we want to talk about is what can we be doing in our own facilities and doing ourselves professionally as we get back to work to make sure that we're taking the proper steps, that we're watching for the symptoms and the effects of the disease. And really, you know, what can we do to help everything get more or less back to normal, or at least get working again, and minimize the impact that this disease is going to have on all of us and on the economy. A lot of you know I do classes and I talk a lot about risk management and supply chains and tools and processes we can use to identify and manage risks. With where we're at with coronavirus, my family and I actually had a family meeting last weekend and started thinking through, what is the probability that we will end up being infected by coronavirus as a family? How would that impact us, and what sorts of steps should we take now to prepare for that? And so we worked through several different scenarios that I get it, that my wife gets it, that we all get it, and began to understand, how it happens will impact what we need to do to be prepared for it and to manage it. But what we realized was that in every one of those scenarios, step one in our plan had to be call Dr. Akampura and let him know so that we can get tested and start taking the right steps to take care of the family. Dr. Carl, I know up in Richmond where you are, you've had a handful of cases and you've even had some patients that have made the COVID-19 journey. Can you tell us a little bit about, what that was like?
Oh, happy to, Daniel. Yeah, we've had two cases come through our clinic over the past month. I'd like to talk about them, and also another case I'd like to mention to everybody. A doctor friend of mine who ended up being hospitalized. The first patient was a 70-year-old something woman who was flying back from the West Coast. Called me after she got in town and said, "Doc, I've developed this dry cough, and I've heard about the COVID-19, and I'm just curious if I may have developed it." I said, "Do you have any other symptoms?" She said, "Yeah." She says, "I am just so fatigued." She said, "I am sleeping 13, 14 hours a day, and that is just not like me. I am a go-getter, and it's just unusual." And so I said to her, "Come on in. Let's go ahead and test you." There's two types of testing out there, by the way. One where we take a viral swab, and we swab both the nose and the throat. And that will tell us if somebody actually has the virus. If they've had it for a few days, they probably have developed some sort of viral load where we can check that. And sure enough, this particular patient tested positive. And so she went home and she quarantined herself, stayed away from her husband. He brought her the food to the door, and she stayed away from the grandkids. And we were treating it relatively conservatively, just with Tylenol and fluids. I did start her on azithromycin, a Z-Pak, due to the fact that she was having a little bit of a productive cough. And there was some mention in the medical literature that it may help improve, not cure, but potentially help improve COVID-19 symptoms, which would be unusual, right, as it is an antibiotic and not an antiviral. But as an antibiotic, it also seems to decrease inflammation and have some antiviral properties. So she did get that. I did not give her hydroxychloroquine, which I'm sure most of you have heard about or read about, and she was already taking zinc on her own. As it played out with this particular patient, she came back in 3 weeks. She came back in 2 weeks. I retested her viral load, and she was still positive. So I sent her back home and said, continue to quarantine. Continue to do what you're doing. And again, she never felt bad enough to go to the hospital. But she continued to have the symptoms that I spoke about earlier. She followed up with me again 2 to 3 weeks later, so this would have been about week 5. I retested her viral load and it was gone. There was no virus detected in her body through the swab. At the same time, Daniel, I checked her antibodies through a blood test. And sure enough, she had developed antibodies, both IgM and IgG antibodies, which may or may not confer immunity or protection. We're not sure yet, but it made her feel better, and it actually made me feel better. And at that point, I did allow her to go back and start to at least be with her family and grandkids. I still asked her to protect herself. So I didn't know where the grandkids had been. By the way, the grandkids had been with her out in the West Coast. So I tested the whole family, her husband, the grandkids, her daughter, all tested negative. She was the only one who tested positive. And it was interesting. You could argue, well, she was the oldest, certainly, and just age itself puts you at greater risk. But beyond that, she really had no other, what we call medical comorbidities. She did not really have diabetes or cardiovascular disease or high blood pressure. She really didn't. She was otherwise a healthy lady. Good news is after 5 weeks, her symptoms more or less resolved. And she went back to doing what she does well. And she's a wonderful business person and brilliant. And, I was so thankful, particularly at her age, that she ended up not having to go to the hospital. Once you have to go to the hospital, then your risk of not doing well is obviously much greater. The second case that I thought was interesting was another patient of ours who was in her 50s. She was in a wedding down in South Carolina, and I think it was at Kiowa or Charleston. I can't remember where, but people were coming from all over the country. This wedding from New York, from LA, and different places. And she was certainly exposed because somebody had mentioned that they had been exposed. So she had been exposed. She came back to Richmond after the wedding and called us and said, I can't smell anything. And we said, really? She says, no, I can't smell anything and I can't taste anything. And she had a low-grade fever, a little bit of hoarseness, but not much beyond that. We brought her into the office, curbside, tested her again through a viral swab, and she tested positive. She was, again, in her early 50s or so, and she called us a few days later and said, you know what? I'm 100% better. My taste has come back, my sense of smell has come back, and I feel like myself again. So her symptoms only lasted 2 to 3 to 4 days. We brought her back again 3 weeks later to see if she had developed antibodies, and she had not. So what do we make of that? Right? She tested positive through the virus. She had the symptoms. One of the first symptoms we're seeing now is loss of smell, which makes sense. It's the first place it goes: nose, throat, upper respiratory. It made perfect sense to us. And yet she hadn't developed any antibodies. So the question is, was the first test wrong? Was it a false positive on the viral swab? Or is the antibody test not quite good enough yet? And it didn't pick up what we had hoped it had. Now, it picked it up on our other patients, so we felt like it was a reasonable test. So we're stuck with that a little bit, right? Good news for both of them, they're both well and thriving. Didn't have to go to the hospital. The third case that I found interesting that I'd like to talk about for a minute was there was a physician in Richmond who's not a patient of the clinic, but is well known in town, and he went to England about a month or so to pick up his son. As everybody's read, Italy's gotten hit hard, England's got hit hard. He went and picked his kid up, came back to Richmond, and just wasn't feeling well. Just wasn't feeling well. And symptoms got worse and worse. And finally, it got bad enough where he went to the hospital, went to the ER. They tested him for COVID. He tested positive. They kept him. He was. They were doing what the normal things that they do. Again, I'm not sure what he got at the time, whether it was antibiotics or hydroxychloroquine or zinc. I'm not sure what he got, but he was becoming hypoxic. It was coming to the point where they were having to consider putting him on the ventilator. And fortunately, he was being followed by a pulmonologist in town who said, well, wait a minute, let me try something. Maybe it's not the virus. Maybe it's your immune system that is overreacting so tremendously that you've developed what they call the cytokine storm. And sure enough, this pulmonologist gave his patient this doctor friend of mine, something called interleukin-6 antagonist, where he tamped down his immune system. It's a little bit of a scary thing to do, right? Because we certainly don't want to tamp anybody's immune system down. So it's a timing thing. But at this point, it was felt like it wasn't the virus that was causing all this extra interstitial fluid and this inability to move oxygen. It was actually his immune system overreacting. And sure enough, within 12 hours, the doctor, quote, patient felt much better. He got one more dose, and the next day he was himself again. And they let him go the following day. And the reason I tell that story is because we're learning new things each day that I think at some point we're going to have more and more effective treatments for this terrible virus that's caused this pandemic. So I like to tell that story.
One of the things that we talk about in supply chain risk management a lot is you want to be able to detect a threat early because you have more options to respond, and you want to do things that buy you time because in that time you can do things to respond. And I think this is a great example that translates into the medical world, right? The longer you can push out an infection, the more we're going to learn about what's happening in the disease and what works in trying to treat it.
Well, it's such a good point, and that was why originally when they talked about, quote, flattening the curve, that's what it was all about, right? Giving us time to come up with a potential vaccine and an effective treatment. And oh, by the way, not have the hospitals so overrun that the healthcare workers couldn't take care of the people who were so terribly sick. And so that was the whole idea. So it's a perfect analogy. So I agree 100%.
So that's a great segue to one of the things I wanted to ask you about, which is, okay, we have diseases, we have viruses. That's not new. What's different about what's happening right now?
Yeah, really great question. This COVID-19, it's a very tricky virus, very tricky. If you compare it historically to, say, 2003, where we had SARS. SARS was also a coronavirus, but SARS was a dumb virus. It was a dumb virus in the sense that it was horrible in that it killed people, but it killed them right away. You were so sick right away that the virus really had no place to jump because you were either at home or in the hospital. You didn't go anywhere. This virus is much different. It's got a long incubation period, but a high infectivity rate. And if you think about long incubation period, what that really translates to is people are, quote, pre-symptomatic. They've been exposed, they have the virus, but they don't know they have the virus. And so they're walking around with friends and family, not recognizing that they're carriers and causing a problem because they don't feel bad. So how different is that than, say, SARS, which we talked about a minute ago, or just the seasonal flu? You get the seasonal flu, within 24, 48 hours, you're going, God darn, I don't feel good. There's something that's hit me here. That's not the way this virus works. This virus is hanging out. And not only are you, quote, pre-symptomatic and don't really, quote, have many symptoms at that point, but the viral load is highest days, 2, 3, 4, 5, when you don't know you have the virus. And so it's a double whammy. And so by the time you kind of figure it out, day 10, 11, and 12, well, daggone it. You've been around a bunch of people not knowing that you were the problem, that you were the vector. And so that's why it's been so tricky. The other difficult part of this virus, it's a family of coronaviruses, right? Again, we talked about SARS, MERS, all coronavirus, HIV, a coronavirus, the common cold, one of the coronaviruses, right? Some of them mutate. This one doesn't seem to mutate as much as some of the others, which may potentially give us a chance to develop a vaccine. But it's difficult in that we've been trying to develop vaccines for these other coronaviruses for the common cold for 60 years. Haven't come close. We haven't come close. And so, again, getting back to your idea of giving us some time to figure this thing out makes perfect sense. The good thing here is we have the whole world working on this problem. Right? All the smart people, all the scientists, all the countries, because it's been so devastating from both a health standpoint and an economic standpoint. It's a global pandemic, so the brightest people and the brightest minds are working on this thing. The other thing that I'd like to mention that your audience might find interesting is how this virus, again, presents itself. It seems to present itself in stages. We talked about the patient that we had in the clinic who lost her sense of smell. Makes perfect sense, right? So the first, again, you may not be symptomatic for a week or 10 days, but at some point, everybody has some symptom, whether it's a little bit of loss of smell or a hoarse voice or a dry cough. That seems to be phase one. And that may last a day or two, and that may be the end of it, or it can progress. If it progresses, it gets further into our respiratory system. You might get a deeper cough, which is phase two. Phase three is actually when you develop pneumonia, which is starting to get serious. At that point, right, people are having a hard time oxygenating. They become short of breath. It's really at stage three where, that 20% of people that have to go to the hospital end up going to the hospital. And, if it progresses to stage four, that's when we're in serious trouble. We can develop acute respiratory distress syndrome and multi-system organ failure. That's when we need to be put on the vent to try to push the oxygen through the system so our organs can get oxygen so they can continue to function. I had mentioned earlier that one of the pulmonologists here in Richmond had given this physician patient an interleukin 6 treatment, which was right in between stage 3 and 4, right? Again, the timing was important, and it worked for that particular patient. And there's some other treatments out there that we are feeling pretty good about, or relatively good about. There's an antiviral medication, remdesivir, which was a drug developed by a company called Gilead. And it's an antiviral medication. And that's a great idea, right? If we can get an antiviral medication and stop the replication of the virus, that's terrific. But it's not a home run. It's not a home run in the sense that they did meet their endpoint and they did decrease the time of illness by 4 days, which is fantastic. The issue there, of course, is it's an IV medication, and it would be better if we could give it earlier. But people don't get it until they get into the hospital. So we need to figure these types of things out. But that's okay, as you said, with supply chain. We're working through this as we can start to try to figure some of these things out.
Doctors, the folks in my community are at a place now that either they're operating facilities that have been, working straight through, or they're starting to come back from this pause and reopen. We're all looking for guidance about how do we do this safely? How do we, get to work, for those of us that can't work from home, do it in a way that we're protecting ourselves, protecting our coworkers, and not, running the risk that we're getting an infection that we're then bringing back home to our families at the end of a shift. Can you share some thoughts, some suggestions, some guidance around how we can be personally doing things to work more safely, and how those of us that are in charge of a facility or a team of people, what can we do to help look after our folks, our customers, and our suppliers?
I just want to lead into that a little bit. I do feel that education is a very, very, very important part. And what I mean the education of the employer to the employee. And I think that education builds trust. And I use the example of our small company, Wellcome MD. So we have a very proactive executive group of people, plus Dr. Neil Carl. And with the advent of this whole process, we have actually had policies and procedures that have been enacted that we were all told about, all explained to, and we enacted them, and we were able to operate our offices like we would normally. We didn't put our patients in jeopardy, nor did we put our staff in jeopardy. So I think that mutual respect back and forth is probably one of the most important things. On a daily basis, what I would make sure that I would do is, one of these big factory type operations, I would make sure that temperatures were taken on a daily basis. Depending upon the type of job and the type of risk, I think gloves are very, very important. I do also think that wearing a mask is not only protective for the people that surround you, but also for yourself as well. So the thing is, if you're sneezing and you're coughing, you're going to make sure you're doing it into that mask, not to the people that are around you. In addition, I think probably the most important thing that we take for granted is hand washing. So the thing is, warm water and soap is probably the best way of preventing spread. Keeping that in mind, if you had the ability to put hand washing stations in the particular organization that you work in, I think that in effect will also help tremendously. If not, you have hand sanitizer. Hand sanitizers, as long as it's 60% alcohol or better, will prove to be very, very beneficial. But again, going back to that trust, I think that you have to have a safe work environment. I think it's important that as an employee that you feel safe to go to your employer and say, hey, I really don't feel well. I have symptoms, X, Y, and Z. And so then this way you can identify potential problems as the employer. You could take, if those people who present to you with, cough, shortness of breath, difficulty breathing, fever, well, your policies and procedures are already in place. You can identify that person. You can remove him or her out of that position and protect them, but also protect the other people that they are working with. So I think that's also very, very important. Now, the reason I think we're doing so well is the social distancing. And so the thing is, I was thinking about how do you socially distance in a meat packing plant where you have everybody working around you? Interesting thought. So the thing is, I think what you can do is you can stagger the hours of the workforce. And instead of them open maybe 12 hours a day, maybe open 24 hours a day and stagger the hours of the employees. But then again, you have to have all those things in place that I just mentioned previously in order to help the employees.
That's all great. And I tell you, it's interesting that you bring up the example of the meat packing plant. I think a lot of folks are focused right now on the story of what happened at the Smithfield plant back in my home state of South Dakota. And one of the things that I'm starting to see is there may be some things unique about that work environment that make it particularly prone to spreading the disease. So it's a refrigerated environment, which may actually make it easier for the virus to survive. And they do a lot of recirculation of the air, which means that once it gets into the air that it's spreading. And of course, people are working pretty closely together and have a lot of contact. So one of the things that actually comes to mind for me is if there were some way for the folks running a facility to get help from medical experts and disease experts to sort of look around and say, here's what's special about you, or here are some of the things that really make this environment riskier, and maybe we need to take some special precautions to mitigate that. And I don't have a good answer for that, except I know if it were me, I would be calling somebody like my friend Dr. Akampur and saying, hey, let's think through, what's happening in my facility. Let's kind of look at our processes and procedures and see if there are any gaps here that we can learn from. The other thing that comes to mind is just, sharing what we learn with other folks in the industry so that, we can learn from each other instead of all of us learning the hard way.
This has been a terrible, terrible virus. It's probably over 250,000 fatalities worldwide. But there is a silver lining here, and I do believe that, because I don't believe that this is the virus that's going to take away half the or third or fourth of the earth like the bubonic plague did. It's terrible, but but I do believe that we're going to have effective treatment and potentially a vaccine, in the next 12 to 18 months or so. What I think is I think the silver lining here is we're going to be ready for the next one. it's not going to surprise us like this one again. We're going to understand where the hot spots are. We're going to jump on it. We are going to be ready. Every state's going to have warehouses full of whatever they need, and I believe that with all my heart. So, as terrible as this COVID-19 has been, it's going to get us ready for the next one, and we're going to jump on it quickly.
I also want to echo Neil's sentiments in something he said earlier in the discussion with regards to the global pandemic. I'm not technologically savvy, but one thing I have learned from this is the fact that there is such a global presence. People are exchanging ideas and practices via the use of, places with things like Zoom and other ways. So I think that technology plays a huge role. And I think that the global presence does. But I think even more important is the fact that if you go throughout history, Dan, the United States has always been a group of men and women who are resilient. And I think that resilience is going to come shining through, and we're going to make it through this.
I think it really is. It's all about resilience and collaboration. And we're seeing really the need for companies to collaborate up and down in their supply chain, and collaborate around the world, and collaborate with experts like our great healthcare professionals. Thank you both for the work that you do every day, looking after families like ours and all of the families out there. Doctors and healthcare workers really are heroes and saving lives today. We really appreciate everything that you're doing, and we appreciate you taking the time to share your insights and your expertise with us today.
Thank you, Dan.
Our pleasure.
Our pleasure.